intestinal movement, and the malabsorption, which is what it sounds like, right? Nutrients aren't being absorbed where they're supposed to be being absorbed by the gut to get back into the blood. And then third, some miscellaneous conditions, some tumors, vascular issues, congenital things that you need to be aware of. And then the big thing to kind of key in on as we talk about the different disorders of the small intestine are patterns of symptoms, right? For each of these, there's going to be kind of a cluster of symptoms, and if you can pick those out of a lineup and put them together, then that's going to help lead you down your differentials to get to the cause of whatever disorder of the small bowel your patient's presenting with. So malabsorption first, the largest list, right? Celiac disease, Whipple disease, sprue, lactase deficiency, bacterial overgrowth, and then short bowel syndrome. So the big thing with malabsorption is if your intestines aren't properly absorbing nutrients such as fats, carbs, proteins, vitamins, minerals, then obviously we start getting some signs and symptoms from those nutritional deficiencies in our system. As I mentioned, these are the disorders we're going to talk specifically about. So a lot of the symptoms, because they're all malabsorptive for that list, they're going to overlap. But there's going to be some key differences in the etiology, why they're happening, why is this disorder presenting itself in your patient, and then how we treat it. But a lot of them are going to look alike, sound alike. So pick out the key detail that makes one thing different from the other, because they all kind of have the same signs and symptoms except for some nuanced differences. So a couple of definitions: malabsorption, as I mentioned, impaired absorption of nutrients from the GI tract. Pretty straightforward. Basically, this is going to clinically manifest itself in a few different ways, right? Most classic sign, we mentioned it yesterday, steatorrhea, bulky, greasy stools. So if you have an abnormality with fat absorption, you're not absorbing fats well in the GI tract, well, those fats are going to come out of your stool. So that explains why you get steatorrhea with malabsorption syndrome issues. Bulky, greasy stools. Nutritional deficiencies, because we're supposed to, at certain parts of our small intestine, be absorbing certain type nutrients. So if that's not happening due to disorders of absorption in the small intestine, then we start to get those signs and symptoms of nutritional deficiencies. And we'll talk about in a later lecture specifically which minerals, which vitamins, but there's a couple that we'll hit on today that cause some specific signs and symptoms and maybe some different changes on that CBC, right? Either microcytic or macrocytic anemia, because we're not getting the vitamins or the minerals that we need to take in. And there are a couple of other definitions there for you, the difference between maldigestion and malnutrition. Just a review, if you look back at it, but what you notice on the slide is it's just discussing basically where certain minerals, vitamins, nutrients are absorbed in the small intestine. So we'll talk about, like I said, in another hour and a half lecture next week, some specific vitamin and nutritional deficiencies of vitaminosis. But you can see where iron is supposed to be absorbed, folate, and B12, in the duodenum, the duodenum, and the ileum. And so when we get signs and symptoms of those deficiencies, well, it tells us what part of the small bowel that we probably are having our issue in. Or if we get all of them, then it's probably affecting the entire small bowel. So that's a key factor to pick out of these disorders as we talk about the malabsorption disorders of the small intestine. So how do they look? How do they come in? Pretty hallmark findings of steatorrhea, which I mentioned, bulky stools, they're greasy, and they also float. Because basically, as I mentioned, increased fecal fat content. You can also get some anemias with malabsorption. It can be microcytic or macrocytic. We've touched on it briefly in farm. I know you are going to have it in heme as well. But basically, microcytic is going to be deficiency in iron, and then B12 and folate deficiencies are going to be macrocytic. So if you're having just B12 and folate, macrocytic anemias, well, that then tells us, well, it may be in the entire tract. If it's just iron without B12 and folate, then you might get just macrocytic, so that's usually up, as we said on the last slide, in the upper portion of the small intestines where we absorb iron. So there's key things to kind of look at your clinical patient presentation to determine where in the SI or where in the small intestine that we're having the issue. And we'll talk about it a little more in depth in each one. We can also get some dietary intolerance. So if you have problems with dairy products, then obviously you might have deficiency in your lactase. So you can't digest lactose. So starting off with celiac disease, one of the most common is the big one. It's an immune-mediated response to gluten. So what happens is you start to get damage to the proximal small intestine mucosa. Proximal small intestine mucosa. So then when you have gluten exposure, these patients get inflammation, destruction of the intestinal villi. So that's why they can't absorb nutrients properly, because that gluten exposure is damaging the villi that are supposed to be absorbing nutrients. With the celiac disease, often it's just iron deficiency anemia early in the disease, early on. Why? Because we said it's proximal small intestine, that's where we absorb our iron. So celiac affects usually the iron absorption in the proximal small intestine, so then we'll see early on decrease in iron, giving us iron deficiency anemia, microcytic anemia. And remember, this is an immune-mediated response. So what is gluten? What is it? Anybody? Yeah, it's on the slide right. It's a protein. In wheat, barley, rye, grains. There's a few there that I have never heard of, but bulgur, farro, kibbutz, spelt, triticate, malt, and brewer's yeast as well. So what do patients that have an immune response to gluten need to do? Avoid these foods. Avoid everything on that list. Yeah, everything fun's gone out the window. Is compliance going to be an issue with your patients with celiac disease? Absolutely. So these symptoms that we're going to talk about for celiac disease are the ones we mentioned patient presentation. They're subtle, right? And they're chronic. So some of your patients are going to have symptoms kind of showing themselves minorly in the background for years and years before they actually get the diagnosis. So you really have to have a high index of suspicion for celiac disease. Because if you don't look for it, you're never going to diagnose it. So you have to be thinking about it to look for it and then find it. Manifestations, GI manifestations of celiac disease. Chronic diarrhea, once again, the steatorrhea, abdominal bloating, flatulence, weight loss. So it sounds like a lot of the disorders we've been discussing this week, right? They might also have that borborygmi, right? Those loud abdominal noises on auscultation that sound like the word, right? That's what you're going to hear. So excessive gas movement. Prolonged malabsorption can lead to muscle weakness and muscle wasting and profound weakness. Why? It's a nutritional deficiency because of that degradation of the villi, the upper GI tract. like I mentioned, if you see steatorrhea, you're always going to first kind of put it over in the bucket of, well, we got malabsorption going on, right? But then we have to figure out what's causing the malabsorption. Iron deficiency is another, so microcytic anemia is another clue when we start talking about celiac. So it's also not just a GI disorder. Why? Because the GI tract absorbs all of these nutrients that we need for normal functioning and homeostasis. So it can produce a wide variety of extraintestinal manifestations. These are big, right? So if you got the steatorrhea, you got a malabsorption, you got an iron deficiency anemia, and then you're also seeing some fatigue, some depression, as I mentioned, iron deficiency anemia in your females, amenorrhea. You could also see signs of vitamin D deficiency, so osteomalacia. And then dermatitis herpetiformis is a specific derm presentation from celiac that we're going to have a slide on, but you definitely need to know that. Dermatitis herpetiformis. Sounds like virus, right? Sounds like herpes virus, but it's not related whatsoever to a virus. It's celiac disease, and that is a pathognomonic board question. And then atrophic glossitis, so that's what you're seeing. The positive arrow there for the tongue, it's red, it's flat, shiny. We'll talk a little more about it. But due to vitamin deficiency, atrophic glossitis. So here's the cutaneous manifestation of celiac, dermatitis herpetiformis. Very, very itchy, intensely pruritic, papules, vesicles on the extensor surfaces. What are those? The elbows, the knees, also your scalp, trunk. It resembles herpes lesions. It sounds like herpes lesions by the way it's named, but not related at all. No viral infection. This is from the celiac disease. So mild cases, completely normal. Like I said, it can go undetected for years. Usually unremarkable physical. Until you start to get nutritional deficiencies and those signs and symptoms we just discussed. So if it gets really bad and you have really, really bad nutritional deficiencies, so we're going to start seeing the pallor from that microcytic anemia. So the oropharynx, the gums, they're not going to be white, right? They're going to be pale. Muscle wasting, the glossitis, showed you the picture, shiny red tongue, and then other signs of vitamin deficiency. Take home point is you got to look for it because a lot of times patients are going to come in normal unless they get to this advanced stage of malnutrition. What do we do for it? Most important thing you're going to do is get an IgA tissue transglutaminase antibody test. IgA TTG. You're going to do your basic workup, which we've done on all of our GI, our patients with GI complaints, the CBC, the CMP, probably UA, but the serology, specific serology to test for celiac disease is there on your slide, the IgA TTG antibody, test of choice. But also draw with it a serum IgA, because you could get a false negative on the IgA TTG if your patient has congenital decreased IgA levels. That's why you get the total serum IgA, because your patient may have an IgA deficiency, so it's going to give you a false negative. So those two go together. When you're looking for the IgA TTG, make sure that your patient has normal IgA levels. And if you have an IgA deficiency that comes back in that lab, then you're going to get an IgG deaminated gliding peptide antibody. So this is a separate antibody that helps you detect celiac disease, specific for celiac. And we'll use that one if you don't have normal levels of IgA. So it's a different test. DGP-IgG. So if they have IgA deficiency, we want to figure out if they have celiac or not, then we move to that test. So serology is the lab test that we do first. Initial screening. And there's just a definition of what IgA is, just a reminder, hopefully. So what does it do? Mucosal immune defense. Protects your mucosal surfaces from microbes invasion. Keeps immunity and homeostasis in the GI tract. Like I said, if you have deficiency in IgA, then it's going to throw off your specific test that we mentioned for celiac, so then you do the second test. So we're going to first do serology for celiac disease, right? But then we have to diagnose, as I mentioned yesterday, a lot of times you get the histological diagnosis, not the serological diagnosis. Now histological, you've got to go in with an upper EGD, take a sample, and let somebody in a lab look at it and say, yep, this is celiac disease. So that's where you're going to see the atrophy of those villi, and you can also get some crypt hyperplasia and signs of inflammation. So if they're really severe, the mucosa will be flat. You won't even see the villi. So a flattened mucosa with a loss of the villi. So serology first, and then we're going to go for the gold standards, biopsy in the upper small intestine, in the duodenal biopsy during endoscopy. That's the confirmatory test that you're confirming the serological antibody result. I would know that. And there's just what the microscope lookers see. The tops is normal, and you see they're long villi, and then down on the bottom you see the atrophy of those villi. And that's the reason that we're not absorbing our nutrients properly in the upper small intestine when we have celiac. Differentials, irritable bowel, which we have a whole lecture on. Chronic diarrhea, which we've already had a lecture and a half on. Tropical sprue, we're about to talk about. Lactose intolerance as well. And gastroenteritis, which you've had numerous lectures. So those are all your differentials. So you can narrow it down to another malabsorption syndrome, type of stools, and then we start looking for those specific things that lead us more to one of these diagnoses or not. And we talked about what that would be with celiac. Diagnostic approach. I don't like the way that's set up there. So the histopathological exam, obviously that's when they're looking with the microscope. Is that what we're doing first though? So it shouldn't be first on the list because you're going to do serological testing first for those antibodies. Then we're going to get the EGD and the mucosal biopsy, and then the microscope lookers will look at it, the histopathological exam. And what do? First, stop them from, or try to stop them from having gluten in their diet. So they'll have to look up the entire, probably book. I think there is one on the slide here, a book of what food and beverages have gluten in them, and then try to eliminate all those. So you're going to get the IgAs, we mentioned which ones. Oh, look, it's positive, let's confirm. EGD, biopsy, yes, we looked at it under a microscope. Yes, we saw this flattening of the villi, or the loss of the villi. So it is celiac. So either way, gluten-free diet. Try to get your patients on a gluten-free diet. So get it out of their diet, including oats. Small oats do have a small amount of gluten in them. I and most folks just refer to a nutritionist. You can do the gluten-free diet, but for long-term control, get a nutritionist on board. Usually, you're going to see within a couple of weeks these patients are doing better if they're actually following your advice and eliminating gluten from their diet. Nutritionists will be helpful in these celiac disease patients to avoid gluten. If they follow a gluten-free diet, excellent prognosis. You can reverse those nutritional deficiencies pretty rapidly. You'll see the anemia start to turn around. There's signs and symptoms getting better. Most common reason for treatment failure, obviously, is adherence to a gluten-free diet. Because it's in everything, right? Lots of gluten in processed foods as well. Small amounts can trigger the symptoms to come right back. So if they decide to take a gluten-free holiday and start putting some gluten in, even small amounts can start to have the reoccurrence of the symptoms which we talked about. If folks have untreated celiac disease, they do have a slight increase for intestinal lymphomas and small bowel adenocarcinoma. So cancer risk mildly elevated for untreated celiac disease. If the gluten-free diet works, okay, cool, that's what they do. If their symptoms persist, or it's a particularly difficult, challenging patient, you refer to GI, and like I said, you can also refer to a nutritionist to help them with their strict dietary adherence, which is essential, right? Avoiding gluten. Okay, now we're moving on to Whipple disease. Done with celiac, but where we're at, we're still in what? Malabsorption problems. Still in malabsorption of the small intestine. So Whipple disease, rare, but it is an important cause of malabsorption syndrome in the small intestine. It's an infection with a bacterium, T. whipple, Trophimeri whipple. Multi-system illness, which means GI tract and then some. Usually this is going to affect white males between 30 and 50, and it's increased incidence in those who have an occupation where they work in soil or wastewater, farmers and sewage workers. Because the bacterium is in in the sewer, in the wastewater, and obviously if you're a worker in those areas, you're more exposed to it, so that's why the incidence rate are higher. Can be fatal if undiagnosed. If you don't treat Whipple disease, you can die. Your patient can die. So rare, but high mortality from it if untreated. Triad. Know the triad for Whipple disease. Migratory arthralgias, usually your large joints, and that's usually very early. Your patient's going to have these large joint arthralgia, joint pains, joint issues, long before they start to get the chronic diarrhea and the weight loss. It's important when we're talking small bowel because it's a problem with getting our nutrients from whether it be malabsorption or some of the other classes we're going to talk about. That weight loss is often there because we're not getting the proper nutrients in. So we've been talking most of the other lectures, upper GI stuff. If we see weight loss, we start thinking cancer. It's still in your alarm findings, but anything in small bowel that's affecting your body or your patient's body absorbing proper nutrition, vitamins, minerals, those kinds of things. A lot of times with small bowel, you will have weight loss. It's still a red flag, but just know it is common in small bowel issues. And in late Whipple disease, weight loss. So starts with some joint pain, moves on to chronic diarrhea. It's malabsorption, so what's that diarrhea going to be? Foul, smelly, fatty. So obviously steatorrhea is what we're talking about. Often delayed diagnosis with Whipple disease. Once again, we're not really thinking about it. They had arthritis, joint pains. Well, they're farmers and sewage workers, so they're probably doing something pretty physical anyway. So we say, it's just normal wear and tear on your system from your occupational exposure, right? from your occupation. And then later on, now they have this abdominal pain and diarrhea with steatorrhea and flatulence. Start losing weight, so it's kind of difficult to link those all together. That's why it's delayed often for diagnosis. We have some less common signs, but they can still present. Skin can get hyperpigmented, generalized lymphadenopathy. So if you see that, you're worried about something systemic is going on, right? And then ophthalmoplegia or nystagmus. What's ophthalmoplegia? Paralysis of the muscles that move the eye. So these patients have difficulty with either one direction or other direction. So we won't get into that whole SO4, all that good stuff. But one or many or all of the muscles that control the eye movement can be affected, so they can't shift, their eyes don't move together properly, and then the nystagmus is that beating of the eye. So it affects the muscles that control eye movement. So ophthalmoplegia and nystagmus. How do we determine? Well, once again, microscope looking, right? Small bowel biopsy. Pathognomonic on your boards, Whipple disease shows foamy macrophages with the bacteria in them. What are the macrophages? White blood cells, right? What do? They're like Pac-Man. They're garbage collectors. They go in and they eat toxins of bacteria, other things that are around. So when you get this biopsy with Whipple, foamy macrophages is the macrophage actually has the bug in it. It actually has, I think the next slide shows that. So there's bacterium in that sample showing the foamy macrophages. I will know foamy macrophages in association with Whipple disease. There's just a slide for the visual learners, including some of the signs and symptoms, and then discussing the foamy macrophages. What do? Prolonged antibiotics. Prolonged. Usually ceftriaxone, IM penicillin for a couple of weeks, and then some GMP SMX for a year. So we say prolonged, just prolonged. And you have to have prolonged therapy to prevent relapse, because it's going to stay in the system if not. So you're going to be taking the TMP SMX twice a day for a year. Whipple. Moving on to tropical sprue, not to be confused with celiac sprue. So celiac disease, for our purposes, we're going to call celiac disease. Tropical sprue, we're going to call tropical sprue. Both malabsorption syndromes in the small intestine, but different. This one is really based on location. That's why it's named tropical sprue, because it happens in tropical regions near the equator. It's thought to be infectious. We don't really know. Exact cause has not been identified. The difference between tropical sprue and celiac. Tropical sprue, not just upper SI, not just upper small intestine. This is the entire thing. The whole caboodle, small intestine, tropical sprue. Widespread malabsorption. There's its locations relative to the equator. You don't need to know that for the exam or board. Just know what happens in tropical environments. And if you want to learn, everything fits in that narrow band between north and south of the equator. How do they come in? Well, it's a malabsorption syndrome. So guess what? Steatorrhea. Chronic diarrhea with steatorrhea. Weight loss, again, because of deficiency of absorbing vitamins and minerals. Fatigue and malaise. Key feature here, because before now it sounded a lot like celiac. Key feature is because you're now affecting the entire small intestine, you're going to have not just iron deficiency anemia, but you're going to have megaloblastic anemia with folate and B12 deficiency. So You're not gonna have the iron now, so you're not gonna have a microcytic, which you got because that's where the iron's absorbed in the upper SI. Now you're going to get the megablastic anemia because you have folate and vitamin B12 deficiency. And if you go back to the chart, you can look and see where folate and B12 are absorbed, jejunum, ileum, respectively. Just like with the celiac disease, we can get some glossitis and cheilitis. So cheilitis is a new one for tropical sprue, and we got a picture showing that inflammation at the corners of the mouth. The glossitis is that beefy red tongue. The big key here is now we're going into we'll see a megalastic anemia, macrocytic. Chronic diarrhea, we talked about it, fatty stools, greasy fatty stools, malodorous, weight loss, anorexia, they're not hungry, fatigue, malaise, because we're having some deficiencies in nutrition. And now because we have the B12 and folate, now we can see glossitis and cheilitis, which is shown in that picture there. Inflammation and redness of the tongue and at the corner of the mouth. So I mentioned the key features, the folate and B12 deficiency causing megablastic anemia. Diagnosis is usually endoscopy with a biopsy. Looking at it under a scope. So with this, the classic finding is going to be flattened duodenal folds, shortened villi, and inflammatory inflammation. So it sounds a lot like celiac under microscope as well, correct? Shortened, blunted villi. Travel history is what you need to pull out of this one, right? They've been in that tropical area north and south of the equator, because that's the only place that it lives. Long-term antibiotics, again, not as long, about a third of the time, or a quarter, but tetracycline and doxycycline for 3 to 6 months, and then we have to correct their folate and B12 deficiency. So we have to give them supplements of folate and B12 to get rid of the nutritional deficiencies in their anemia. How can we prevent it? Well, it's in the water, so boil water, and then bacteria can hang out on the peeling of fruit, so peel them. The covering of fruit, rather, so peel them off, less chances of getting bacteria in your system. Just a little trivia, sprue is a Dutch word for inflammation of the mouth. If you remember that, then you can remember some of the signs that we see with cheilitis and glossitis. Inflammation of the mouth. Okay, moving on to lactase deficiency. Lactose intolerance, lactase deficiency, same thing. You don't have lactase, so you're intolerant to lactose because you can't break it down. Lactase is an enzyme, it's a brush border enzyme, and it breaks down lactose into glucose and galactose. So when you don't have it, lactose floats around in your system, and it's undigested in the intestine. So then the bacteria that are mostly in the large intestine will start to ferment it. And that's going to give you lots of gas and lots of organic acids, which are going to cause the symptoms of a lactase deficiency or lactose intolerance. Can't absorb the lactose, so then the bacteria in the gut, in the large intestine mostly, produce gas and other organic acids leading to symptoms. What are they? They're usually dose dependent, so a small amount of lactose may be fine. A little bit of milk, a little bit of yogurt may be okay, but moderate is when you're going to have bloating, abdominal cramping, and flatulence. You can actually get osmotic diarrhea with large amounts of lactose if you're lactose intolerant or lactase deficiency. Usually the symptoms are going to come about within 1 to 2 hours after you have your dairy product. You'll start to get the bloating and abdominal cramping and flatulence. Usually physical exam, not too much. May have some other signs of malabsorption. Key negative part of the history. If you see weight loss, it's not lactose, right? It's malabsorption, yes, it's a malabsorption issue, but it's only for lactase. So you're not having problems with B12, folate, so you shouldn't be having weight loss if it's just lactase deficiency. So what does that mean? If you're trying to rule in or out, if you think it's a malabsorption issue and there's weight loss, move away from lactase deficiency being the culprit. Look for something else. Usually for these folks, we don't do laboratory testing. What do? Lay off the milk or dairy products for 2 weeks. If that helps, yep, you're lactase deficient or lactose intolerant. If you do need to confirm it, which usually isn't required, there's a hydrogen breath test. With that, they usually give you lactose in the lab and they basically breathe into a bag and they measure the hydrogen in it and say, yep, you can't break it down. Reduce the diet. You can titrate the patient's symptoms, i.e. if they can have small amounts and have no symptoms, then we're good. Nutritionists can be used here as well. A little more straightforward, avoiding dairy products or things with lactase, with lactose versus celiac, which is much, much broader list. But you can consider referring to a nutritionist. Also, to reduce the lactose intake, obviously if lactose is what's causing the problem, you need to decrease the amount of lactose. You can also, if they can't tolerate small amounts, we can do products that have lactase in them, and we can also give a supplement. An enzyme, a lactase enzyme supplement. Long-term management, consider that dietary counseling. We're moving into another malabsorption issue for the small intestine. SIBO, not to be confused with a bowel obstruction later in the small bowel obstruction. Small intestinal bacterial overgrowth is SIBO. Basically, bacteria that's supposed to be in large intestine overcolonize the small intestine. So normally, small intestine's got not a lot of bacteria, but in SIBO, small intestines get overgrown with bacteria. So exactly like the name says. Excessive bacteria colonizing the small intestine is SIBO. And how can that happen? Well, certain conditions, taking a PPI, long-term, a chloridia. So you've got that PPI on board for years and years and years, decreasing the amount of acid that's made. And so now we start to get overcolonization of bacteria in the small bowel. A lot of times anatomical abnormalities. So think about strictures, diverticuli, fistulas, so something that's mechanical, right? Previous surgeries, so a complication from a disease like IBD, Crohn's or ulcerative colitis. So diverticuli, strictures, fistulas, so those anatomical abnormalities that sometimes allow bacteria in the small intestine that should be hanging out in the large intestine. And also motility disorders. So if you're not moving the food, the products of digestion into the large intestine at the rate it's supposed to go, and things are just hanging out in the small bowel, then you start to get bacterial overgrowth. And then a fistula, like a tract, right, between the stomach and the colon. What are the symptoms? Well, it's a malabsorption issue, bloating, abdominal pain, diarrhea, steatorrhea, weight loss. Also the macrocytic anemia from B12 deficiency. Non-specific findings, if anything, or the physical. You can do a hydrogen or methane breath test. Looks a lot like what we said for the lactase deficiency. They give you like, glucose or lactulose usually, and then they measure how much you're breathing out of hydrogen or methane to say, yep, you've got too much bacteria in your small intestine. How do we treat it? Usually empiric antibiotics, which will cover enteric, aerobic, and anaerobic bacteria. So Cipro, Augmentin, rifaximin. For SIBO, I would just know what it is, and that it is a malabsorption issue in the small intestine, and that we would treat with antibiotics if you have it, if your patient has SIBO. Okay, short bowel syndrome, different from SIBO. So what happens here? Well, you have a short bowel because usually some of your bowel's been resected. Some of your small intestine have been surgically removed due to something. Something has made it necessary to reset part of your small intestine. So now it's short. And if you don't have enough of it there might be not enough small bowel left to keep up with the nutritional requirements of your body that your body needs. So it's dependent on how much of it they took out, so the length of the resection, where they took it out. We talked about in the very first slide or second slide where certain nutrients are absorbed in the small intestine. So what portion of the small intestine was removed can affect what nutrients were deficient in. And then how much can the other portions of the small bowel adapt for absorption. The type and degree of malabsorption from short bowel depends on those three things. So this is intestinal motility disorder. So now we're not having a problem with absorption, we got a problem with movement in the small intestine. Movement of intestinal contents is impaired. This isn't about absorption. This is like physical. How is it going down the tract, right? And the three big things we're going to talk about is an acute paralytic ileus, a chronic intestinal pseudo-obstruction, small bowel obstruction, not to be confused with SIBO by acronym SBO, small bowel obstruction does not equal SIBO, small intestinal bacterial overgrowth. And then also we'll talk about intussusception. So acute paralytic ileus. Nothing's moving through the small intestine, right? Failure of peristalsis. However, there can't be a mechanical obstruction. What would a mechanical obstruction be? Something physically blocking the small intestine. Fecal material, a gallstone, a tumor, something's there, or an anatomical issue, right? It's something that's actually impeding the flow of the products of digestion to move through the small bowel. It's not acute paralytic ileus if it's caused by something mechanical. Usually, hospitalized patients are going to have your acute paralytic ileus. No mechanical obstruction, but they're usually recovering from an abdominal surgery. And you get that acute paralytic illness. Can also be from a severe illness, sepsis, your systems are shutting down, some kind of trauma. Then opioids is your big medication player. Opioids are any anticholinergic that actually stop peristalsis or slow it. Acute paralytic ileus from meds, your scheduled meds, your opioids, the ones that are usually the culprit there. Just remember, acute paralytic ileus, usually the clue from the boards is going to be patient recently had some type of GI surgery. You have to be able to kick that out of the stem and go, oh, now what? Oh, now we're going to talk about the symptoms, but it's leading us towards acute paralytic ileus. Or they had surgery and their own opioids. That's a double whammy, right? To slow down the peristalsis. Usually, diffuse abdominal discomfort, abdominal distension, nausea, vomiting, constant abdominal pain, usually within 72 hours of the surgery, if that's that hospitalized patient and not from one of the other causes. Sepsis, which they probably will end up in the hospital with sepsis, or they will, or an injury. What is your key physical exam? You don't hear the board, what do you hear? Nothing. Nothing. Absent bowel sounds. Diminished or absent. I would know that. And they can have some mild tenderness palpation, but you don't get peritoneal signs. You're not getting that rebound tenderness. You're not getting that muscle guarding. So they had surgery. Within 3 days, now they got severe abdominal discomfort, abdominal distension, nausea, vomiting, and you throw the stethoscope on the belly and you hear nada. What do we do for it? First, we rule out that there's something mechanical going on. Is there anything anatomical, or is there something physical, i.e. mechanical, that's causing this obstruction? So it's not acute paralytic ileus if you can find something anatomical or mechanical that's happening. A lot of times, just your non-specific lab, CBC, CMP, lab studies, non-specific usually. The history is the big thing, and then that absent bowel sounds, which move you right towards it. If you don't have a mechanic, if you don't find anything wrong with it. So imaging, pathognomonic, distended gas-filled loops of the small and large bowel on that plain film X-ray. A lot of times we're going to get that plain film, and then we're going to rule out an obstruction, a mechanical obstruction with the CT. You'll see both on the order. If you're trying to rule out a mechanical obstruction, and if all you see are those diffuse gaseous distensions of the small and large bowel, no other signs of obstruction on the X-ray, and then you get the CT, no other signs of mechanical obstruction, okay, yeah, it's acute paralytic ileus. There's just a picture of the two X-rays, just showing those diffuse air in the small and large bowel. And management is just supportive usually, correct? Whatever underlying illness is happening. So on opioids, get them off the opioids. Maintain fluid and electrolytes. What else do you do? Well, you don't want to put anything else into their GI tract. So they're nothing about mouth. NPO. Bowel rest, right? Because you want to take the pressure off of that small intestine working. NPO with bowel rest. And if they get severe abdominal distension or vomiting, then we can put a tube from the nose into the stomach and upper part of the small intestine, so NG tube, to decompress, right? We put that tube in, we put some suction on the end of that tube, and we decompress the system. Usually within a few days, they're better. I would know the treatment for acute paralytic ileus. All right, so 10 minutes, and then we'll talk about small bowel. Small bowel.
Do you have that? Yeah, I can literally hear it. It's like
I can take off my.
you do what?
I can take off my computer.
Okay.
Actually, I can make the computer here. It actually even fits. Is it messing with your recordings again?
Yeah. I mean, no, it's not messing with the recording.
It's messing with you. I'm sorry.
No, you're good. It's just like
You see that-
once I hear it once, then it's like a little bit to the point where I'm like, ugh. And it's like it's not that annoying. It's just once I hear it, then I'm like, oh, shit.
Look at that.
Does it fit?
That's slight. I'll make it work.
Sorry about that.
No, you're good.
Just make sure you make as much of it.
I was standing back for the second hour on the way out.
Yeah, it's fine, man.
Whatever, man. I probably have to actually buy one that.
I don't even hear it. When I was listening to her, I hear her go.
What do you say?
Just swallow it.
Yeah, I could get one this weekend that I have some bottles. No, it can't be basic. One of the higher people.
I'm like staring at it.
I wouldn't. Because for some reason, yeah, I'm gonna go through. I'm gonna go through it.
He's the best quarterback in the world. No, the Mort. He's just wild. Alright, so my choices are black, pink, or ombre. Black, I already have stuff coming in tomorrow. I bought them in the so
I have boxes in there.
never
It's like
be
Christmas.
Never be
I
open.
I'm like, wow.
Oh, what type of surprise is that? Oh yeah, I just got a big pack of that. I had the same pack as I bought it in like no, there's like a picture of different pots. I don't really use it.
I like the pot. I like the spirit.
I haven't used.
Game's my favorite.
I haven't used like one of the different stuff in forever. I just pour like a douse of vinegar in the water and it kind of adds something.
I like the strong smell. So
Oh,
it's
yeah.
like the downy smell.
Yeah.
You like my bucket cup?
Yeah.
It changes color with the temperature. So if I have cold, it'll be bright pink. But if I have hot, it'll turn to like dark blue.
So what's that color?
It's just normal room temperature.
Those green.
Good green.
Those green.
It's light blue.
That's light blue. I mean, I'm colorblind. So.
Here, let's put it with your blue.
Pale gray.
I mean, this is light blue.
See?
That's
This is all the same.
this is Tiffany blue.
Okay, now blow
Tiffany
it in.
blue. Tiffany color. I didn't know she had blue. This core blue number 1 and number 2.
Teals. It's more like an apple.
Honestly, this is probably teal. One of my wife's favorite colors.
No, we have sorry.
To be honest.
It's hard. Yeah. It's hard to choose the one.
Alright, let's go ahead and sit down, settle in. Alright, small bowel obstruction. These are mechanical. Different from the acute paralytic ileus because there's a mechanical or physical cause of this obstruction in the small bowel. Most common, postoperative adhesions. Postoperative adhesion. So this isn't going to be immediately after the surgery like we had in the acute paralytic ileus. This is going to be mechanical, and a lot of times that mechanical cause is postoperative adhesion, or the most common cause of small bowel obstruction. Other causes, they're all physical or / mechanical, right? Hernias, tumors, strictures, volvulus. What's volvulus? Twisting of that intestine, right? intussusception. We're going to hit it in this lecture, but basically, part of the small bowel collapses in on itself, right? Gallstone ileus is another important cause of small bowel obstruction. Some of these are urgent surgical interventions. So for small bowel obstruction, i.e. something mechanically caused, we have to go in and take care of whatever that obstruction is. So surgery, urgent surgery may be involved for certain cases that we discussed. We can classify it in a whole bunch of ways: functional versus mechanical, partial or complete, the whole small bowel, or part of the, or just part of the small bowel. Open loop or closed loop. Closed loop is really bad. There's no outlet, so there's two areas, right? There is cinched off in an obstruction somewhere proximal and also obstruction somewhere distal. So in between, we can get ischemia and necrosis. So closed loop is obstruction in two locations. There's no outlet. How does it present? CAVO symptoms. On a board, right? Board question. CAVO symptoms. They're not going to say CAVO, but you should know crampy abdominal pain, vomiting, and obstipation. What's obstipation? Constipation is you can't pass stool. What's obstipation? Anything, right? No gas, no stool, just obstipation. So you can't pass stool and no flaps. Obstipation. So crampy abdominal pain, vomiting, obstipation from a patient is going to lead you down the road of small bowel obstruction. The pain is a lot of times, it comes in peristaltic waves. So as your gut tries to push the contents of the stomach and upper small intestine down through the GI tract, you're going to get this waves of peristalsis. And so that's the pain's the colicky, crampy abdominal pain is going to happen in those waves. Every 4 or 5 minutes, you're going to get waves of pain as the GI tract attempts to go through peristalsis, trying to push past the obstruction. If it stays, if the obstruction stays for a while later, the pain can become constant. So early on, it's going to be that intermittent and severe fluid waves of pain and CAVO. Abdominal distension is what you're going to find in an exam. Tympany, there's air in that small bowel, and tenderness. We didn't really have the tenderness or the tympany to percussion with the acute paralytic ileus. So that should be one of your clues. Early in this obstruction, hyperactive. Versus what do we see with acute paralytic? So it's paralyzed, we heard nothing, right? Or a very diminished gut sound. But now with a small bowel obstruction, while you're getting that colicky pain as your body attempts to push past the obstruction, or your patient does, you're going to hear increased bowel sounds. What are they? We discussed the borborygmi, loud intestinal sounds, and hyperactive early. Later, you can get those hypoactive bowel sounds. And you're going to see some signs of dehydration. What do we order? CBC, CMP, like almost all GI issues that we've discussed. A UA, serum lactate, because if you have elevated lactate, it is a marker for bowel ischemia. So when your lactate starts going up, you're not breaking down lactate, not enough perfusion to the gut, elevated lactate equals bowel ischemia, so we're probably moving towards the OR. So if they are going to the OR, what do we need to do? Blood type and cross match. Make sure there's no interaction between the donor and the recipient. Initial study, plain abdominal radiograph, upright and supine. Classic finding, you should know, dilated loops of small bowel with air fluid levels. You'll see the difference when I put up the film. You've probably already had it. Hopefully it's a review in radiology, but there were no air fluid levels when we talked about acute paralytic ileus, right? It was just air, but not air fluid levels. The most useful imaging study is going to be a CT. Why? Because that CT will help us locate the cause of the obstruction. Because remember, now we're in mechanical. Now we're in mechanical, so something's physically, mechanically causing an obstruction. CT is going to help find it, where it's at. They're usually done with an oral and an IV contrast. Oral if they can take PO medications. The X-ray, initially, air fluid levels. Then we go to the CT scanner with contrast, and we find out exactly where this small bowel obstruction is mechanically happening. There's your air fluid levels. You can see, below the air in each case, it looks like you have a horizon, right? You got fluid there. That's not what we saw with the acute paralytic ileus, where you just had diffuse gas patterns in the large and small intestine and large intestine. Here you have those fluid levels, which kind of look like a horizon, right? The sea meeting the sky. There's the CT and another X-ray showing the air fluid levels, and then the CT, they're going to use that with contrast to go in and identify exactly where in the small gut we're having the obstruction, and then correct it, a lot of times surgically. Stabilize your patient. Aggressive IV resuscitation, decompression with that nasogastric tube to decompress the gut, get all that air out. Control their pain, control their vomiting, and get them early in with the surgery. Many of these partial obstructions are going to resolve with just conservative management we just mentioned. But if they're a complete obstruction, then it's usually going to be surgery. They will be in the hospital. Most dangerous complication from a small bowel obstruction is the death of part of the small intestine, right? Prolonged strangulation of the obstructed fluid. So you're going to have first dilation, right? Fluid and air building up, which causes compromise of the vessels to the lumen, which leads to decreased blood flow, ischemia, which leads to death of that part of the body. So, most dangerous complication of small bowel obstruction, strangulation and death of the bowel. You need to know that sequence. Ischemia, first the dilation, then the compromise of the vessels, then ischemia, which leads to the most dangerous complication, strangulation and necrosis. And then you perforate, and you get peritonitis and sepsis and general badness throughout the entire GI system. Life-threatening. Moving on to another type of mechanical obstruction. Gallstone ileus. Rare, but it is important for folks that have chronic gallstone disease because it can cause mechanical small bowel obstruction. What happens there? We're talking mechanical, so a stone, gallbladder stone, actually enters the small intestine through a fistula, usually a biliary enteric fistula between the gallbladder and the duodenum. So that stone heads out from the gallbladder into the small bowel, usually duodenum, and we get a mechanical obstruction. It gets lodged there, basically. Usually it gets lodged in the ileum, the lower small intestine. Starts out at the duodenum, but as it travels south, once it hits the ileum, that's the most common location of the gallstone ileus. Older patients with long-standing gallstone disease. So obviously, how do you pick this type of mechanical obstruction out of the lineup? Is you see signs of obstruction and it's an older patient with chronic gallstones. Diagnosis is CT, treatment, surgery. I move to intussusception. I already mentioned it. Part of the intestine telescopes into an adjacent segment. There's a good visual on the next slide, but it collapses in on itself. Infants and young children, most common, usually after some type of illness. We talked about yesterday a childhood issue, very common. Now we're talking about another disease process, a type of mechanical obstruction that is usually your young child. And the classic you're going to see on the boards, and you need to know it, is they present with currant jelly stool. Boards love currant jelly stool equals intussusception in a kid. It's basically, it's the stool mixed with blood and mucus. So currant jelly, i.e. a grape, raisin, currant mixed like a jelly, that's what the stool looks like. It's like a reddish, brownish color, and it's their feces mixed in with blood and mucus. Currant jelly stool, intussusception, most common in kids less than 1 year old. And it's a mechanical obstruction because the bowel or the small intestine section collapsed in on itself. And I'll show you that on the next slide. How do we fix it? Usually with air or a contrast enema, obviously in the OR. What are they trying to do? Basically just push that portion of the small intestine that collapsed in back out. Right? Usually about a 90% success. So just remember, this is another one that's usually kids. Just like the pyloric stenosis we talked about. Remember yesterday? So if you see kiddos, start thinking about one or two, or actually the three things that you need to be worried about. That's mostly in kiddos. So there's just the intussusception. You can see how it just collapsed in on itself. So it's a mechanical obstruction. They go in and get an air contrast enema, and it gets reinflated. Poof, 90% of the time it pops back open, and no longer having small bowel obstruction signs, symptoms, or currant jelly stool. Finally, we're going to talk about some miscellaneous issues, but they're important. Obviously, cancer, neoplasms are important. Protein losing enteropathy. Mesenteric ischemia is a big one, and a Meckel's diverticulum, another kiddo issue. We have three that we discussed by the end of today's lecture that are mostly in our young children. So some of these are huge on boards, so I'll hit the highlights. And like I said, these are just several miscellaneous conditions that affect small. Cancer, primary tumors of small intestine, pretty rare. With GI malignancies, they're normally in large intestine, up, like we talked about yesterday, stomach and esophagus. But they do exist, and if they do exist, well, if you have a tumor in your small intestine, what can it cause? We just finished talking about it. Right? Can be a physical obstruction. It can be a mechanical obstruction. And if you have a tumor in your small intestine, what else can it cause that we talked about yesterday? Upper and lower GI bleeds. Right? So if you have a neoplasm, it can be a sign of a small intestine GI bleed. And weight loss. We talked about weight loss being one of our alarm symptoms, alarm signs for cancer. Most common type, adenocarcinoma, usually in the duodenum or proximal jejunum. We can also have lymphomas if your patient is immunocompromised. We can also have carcinoid tumors. Did we talk about carcinoid tumors yesterday? Yes. Remember, MIN-1 produce what? Gastric acid. And we get that flushing, classic flushing. So a lot of these are going to develop slowly, and almost every GI tumor we've discussed They pretty much develop slowly. They're delayed late, which means that the survivability rate isn't great. Next miscellaneous small bowel discussion is on protein losing enteropathy. So basically, exactly like the name, excessive loss of serum protein into the GI tract. So the protein is supposed to be circulating around in your body, and now we're pooping it out. So we don't have enough protein in our blood. What's that going to cause? Well, usually really bad edema. And usually this is related to another GI disorder. So you're going to get hypoalbuminemia. So we take that blood test, decreased albumin in the blood, and without the protein in the blood, then the fluid shift's going to happen, and so we're going to have edema. Treatment, figure out the underlying cause of why we are losing proteins. A lot of times it's going to be a GI disorder, right? In that IBD category that we'll discuss later next week. Ulcerative Crohn's, ulcerative colitis, or Crohn's. So try to figure out why they're losing it. If it's really bad, give them some albumin. The way you're going to find protein losing enteropathy is draw the blood, decrease albumin, and the patient has severe edema. Mesenteric ischemia, life-threatening small bowel condition. Life-threatening. No blood flow to the bowel. Can be an artery or a vein, embolism, or thrombosis. What's the difference? What's a thrombosis? It grows right there and never leaves home, right? What about an embolism? It came from somewhere else and moved into the neighborhood, right? Embolism. An embolism. A clot from somewhere else. So that can happen in the arteries or the veins, and we can also have vasospasms that shut down the blood flow to our mesentery. And those are non-occlusive. Because ischemia can lead to necrosis, it's an emergency. Pain out of proportion with physical exam. It's in quotes because that's what they're going to tell you on your boards. There you go. Mesenteric ischemia, classic, clinical. This patient is complaining of abdominal pain that is out of proportion with anything I'm finding on the physical. Severe abdominal pain, but pretty normal when you examine it. Right, you go through your full abdominal exam, pretty benign, but they're writhing in pain. Elevated lactase, so that's that tissue hypoperfusion, that's an enzyme that starts going up because we're not breaking it down. Therefore, our tissues, in this case, the gut, the GI tract, is not getting adequate oxygen perfusion. This is a CT angiograph. Pain out of proportion. CT angiogram. We're going to look and see what's causing this decreased blood flow to the mesentery. This is the first time we talked about a CT angiogram. We discussed it briefly with those frail vessels that we can look at in our older patients for an upper GI bleed or lower GI bleed. But this is a diagnostic test of choice in a stable patient. CT angiograph to figure out why they're having mesenteric ischemia. Medical emergency, figure out what's the problem, right? Is it an embolism? Is it a thrombosis? So we either have to cut it out, embolectomy, thrombolytic therapy, bust it out, right, with medication, clot buster, thrombolytic therapy, or do we go into the vessel and open it up with angioplasty, maybe put a stent in it. We correct whatever's causing the decreased blood flow. We'll get a surgical laparotomy with embolectomy or thrombolytics if it has vascular occlusion, or surgical revasculation with a vascular angioplasty and stent. If it's non-inclusive, i.e. it's coming from spasms, shutting down the blood flow, we can use vasodilators and antispasmodics. All right, final topic for small intestine is the meckel diverticulum. Most common congenital abnormality of the GI tract. Most common congenital issue with GI tract. So what happens is there's a persistence of a duct as the embryo is developing. The vitelline duct persists, and it causes an outpouching of the ileum. So we talked about an outpouching of what? The esophagus. So now we got one down in the small intestine. Rule of twos. We'll be on the boards. We'll be testing for you, for sure. Less than 2% of the population, 2 to 1 male, within 2 feet of the ileocecal valve. That's obviously going to be a surgeon figuring that part out. And usually it occurs before 2 years of age. It'll be on your boards, the rule of twos, right? It might not say what are the rule of twos, but it's going to give you that classic, hey, it's a child, and it's an ileocecal valve, close to the ileocecal valve, it's an outpouching, and you're going to have 2 types of mucosa there, right? When you look at the meckel diverticulum, you're going to have your normal intestinal, and then you're going to have heterotrophic mucosa. Usually gastric type mucosa or pancreatic, which shouldn't be in your small intestine. So there's 2 types of mucosas, and that's another 2. And putting all that all together, you start to take meckel diverticulum. Rule of twos. How do they come in? Painless GI bleeds. Well, parents usually bring them in. Because they're usually less than 2 years old. Don't have to be. A lot of the sources say less than 10, but to keep it simple with the rule of twos, we say 2. Actually, you can diagnose it. Usually they present somewhere less than 10 years of age, so a kiddo. So they can have abdominal pain mimicking appendicitis, painless lower GI bleed, and when they go in and if they're looking with a scope, they're going to see that there's ectopic gastric mucosa secreting acid, so that can cause an ulceration. The big 2 are there, the GI bleed and the abdominal pain. Usually, if they're under 2, it's going to be parents telling you what's going on. Suspect children less than 10 who present with painless lower GI bleed without signs and symptoms of any other signs and symptoms of gastroenteritis or inflammatory bowel disease. So it's a congenital abnormality. Any adult less than 40 with GI bleed but no source identified, and you're doing a standard endoscopy, they may find it. So it's usually incidental. In an adult, you're not so much doing a scope and going, I'm looking for a meckel diverticulum. It's probably just going to be an incidental when you're testing for something else. The classic board is going to be that kiddo. Several imaging modalities that we use: a meckel scan, which is basically a nuclear medicine scan, which has an affinity for the gastric mucosa, and you can see the positive arrow sign, that little outpouching down in the small bowel. Capsule endoscopy can be useful. Treatment, surgery. If bleeding is present, like everything we've discussed, we stabilize first, and if we're waiting on surgery, PPIs. PPIs until they can get surgery. And that brings us to memory jog. So we won't go through those. We're going to, in the last 25 minutes or so, we're going to discuss IBS. And then you guys should have almost everything, I think, barring 2 kind of longer lectures and 2 really short ones next week. That way we're set up to do a review on Tuesday, and then we'll have Wednesday to prepare for whatever you've got going on next week besides this test on Friday. Right, so so let me change over. IBS, we've discussed a lot of it already, so it should go pretty quickly. We won't rush through it. If you have a question, please ask, but we're gonna try to get through IBS before you get your ID review. I think it's ID, right? All right, irritable bowel syndrome, not to be confused with IBD, inflammatory bowel disease. IBD is inflammatory, irritable bowel is not. Very common. You're gonna have patients with irritable bowel syndrome. But it's a frustrating disorder for both the clinician and the patient because it's functional, right? It's a functional issue. We can't find any structural things that we can fix, so it's multifactorial. Patients having real symptoms, but you're not going to be able to just do a study and go, oh, here's your problem, this is what we're going to do, and you're fixed. So it's a multifactorial problem, which requires multifactorial treatment. It's a clinical diagnosis, and we base it on symptoms, and we rule everything else out. So on your boards, you're going to normally see patients having either diarrhea and constipation chronically, or predominantly diarrhea or predominantly constipation, and then here's a whole list of stuff that's found out. CBC, CMP, EGD, colonoscopy, everything in the kitchen sink, all negative. So it can be frustrating for the patient and the clinician. So what do? We actually limit testing. It's one of the main things we'll talk about. Once you've ruled out bad stuff, and we think they're in irritable bowel syndrome territory, we actually don't keep chasing something to give our patient. All right, we're going to look at this, we're going to look at this, we're going to look at this, because what does that do? We'll find out in a moment that part of the one of the factors in this multifactorial GI disease process or syndrome process is anxiety or depression. So once we start saying, I don't know, go do this test, go do this, go do this, go do this, giving them all these appointments, they come back negative, 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 what happens to their anxiety levels? Skyrocket. Something's wrong with me, but they can't figure it out. So we're going to talk about how we approach these patients. The biggest thing is recognizing the pattern, ruling out other badder stuff, i.e. the alarm features, which we talked about ad nauseum, and then how do we treat it? What's our stepwise approach? Based on if it's mixed type of IBS or if it's constipation mostly, or mostly on the diarrhea side. Idiopathic functional GI disorder. 3 major features. You need to know these features for IBS. Chronic or recurrent abdominal pain. Chronic or recurrent. Not out of the blue, my belly started hurting today. Right? So chronic and recurrent. I'm sorry, chronic or recurrent. Altered bowel habits. So something changed, right? Something has changed. And we can't identify anything else, which we're going to do first. So whatever testing's been done, it's all going to say within normal limits or nothing found, or nothing that we can treat, right? Lab studies, imaging, scopes, they're normal. So there are numerous extraintestinal manifestations of IBS. And we'll talk at length on those, but we're talking outside the GI tract. Signs and symptoms, right? So what we do is look at the symptoms. So we use a symptom-based criteria to diagnose it. Pathophys, complex, multifactorial. And you can see all the possibilities there. So most of these IBS patients do have some type of abnormal GI motility issue, i.e. physical movement of the products of digestion through the bowels, either too fast or too slow, right? So too slow, constipation. Too fast, diarrhea. Second, pathophys kind of mechanism proposed, right? Because we know it's multifactorial, visceral hypersensitivity. So the intestines are overly sensitive to normal levels of distension or gas, i.e. normal digestion. In your IBS patient, the intestines tend to be more sensitive to abnormal or raises in pressure or gases. Third, gut-brain axis. This is a huge one. The gut-brain axis. So we'll talk about it a little bit more in depth on the next slides. But other contributing factors, we could talk about alterations in the microbiome of the gut, inflammation after there's been some type of infection, psychosocial issues, psychological stress, food sensitivities. So it's a complex interaction between nervous system, immune system, and the intestines. That's how we kind of think of IBS, a complex interaction issue between our nervous system, our immune system, and intestine function. Most common symptom of IBS, both types, crampy abdominal pain. Intermittent, usually in lower quadrants. Here's your take home. You see it, take it out of the lineup. It gets better when they defecate. The pain is better shortly after defecation. Intermittent crampy abdominal pain. I go to the bathroom, I pass stool, it helps a little bit, a little better. Changes in bowel habits, diarrhea, constipation, both, one or the other. Alternating patterns between diarrhea, constipation, or both. And then they're going to complain of that bloating and abdominal distension. Those are your three big buckets for the signs and symptoms of IBS. That crampy, intermittent abdominal pain, change in the stool frequency and form, so either constipation, diarrhea, or both, and alternating, and then having the feeling of bloating or sometimes actual abdominal distension on exam. We talked about the stool chart, so if they're having the IBD, they're going to be down there in that type 7. If they're having more IDC, up there in type 1 or 2, or they can flip between both. 3 major subtypes, I've already mentioned them. The C, constipation is predominant. You need to know the definitions here, or the timing of what the patient is reporting. For IBS-C, patient's going to say, I've got constipation and it's less than or equal to 3 bowel movements a week and I'm straining. We'll give you another tool to categorize here in a second, but here's what your patients, we need to be clued in when we hear less than 3 bowel movements a week and straining. Start thinking IBS-C. IBS-D is diarrhea dominant, that's why it's a D. And this is greater than or equal to 3 bowel movements a day, not a week. Urgency and fecal incontinence. Notice that both subtypes, we didn't just say the number, also included with those other symptoms. Are they straining with less than 3 bowel movements a week? Okay, we're thinking IBS-C. If they have urgency, i.e., gotta go, close to a toilet, or incontinence with greater than 3 per day, then we're looking at IBD, or mixed, a little bit of both. And that's important to categorize your IBS patients because treatment's going to be different. We're not treating diarrhea, we're treating IBS-C predominantly. So the extraintestinal system symptoms, headaches, fatigues, muscle pain. You see the entire list there. Chest discomfort, dyspepsia. For women, they can have gynecological symptoms like dysmenorrhea and dyspareunia. anxiety, depression. So this list should reinforce that idea, right? That it's a issue with a dysregulation between the gut and the brain. Just know that there is a somatic and or psychological complaints. It's not just the GI complaints in your IBS patient. Multifactorial. History is probably the most important thing because you want to rule out other badness, right? So you do that a lot of times with the history, right? You ask about the bowel movements, you ask the frequency, the changes, pain associated, not associated, does it get better when you defecate? But always ask family history of colon cancer. Is there a family history of IBD, inflammatory bowel disease, which we'll talk next week? Is there a family history of thyroid issue? Because hyperthyroid can cause diarrhea symptoms, hypo can cause constipation. Is there any of the malabsorption syndromes we spent an hour talking about a little while ago in the family history? What else? Recent travel, infections, changes in your diet. Did you just become whatever you decided to change your diet to? Has there been any recent changes? Have you given up something or have you started something new introduced in your diet? Any medication changes and also exercise patterns. We talked about the multifactorial issues with IBS. So exercise is actually pretty huge, especially in recommended treatments. So there could be alternative reasons or alternative diagnoses that we need to rule out first. So make sure you get a great family history and patient history. Alarm symptoms. These are not new to us, right? Rectal bleeding, unexplained weight loss, pain that wakes you up at night while you're sleeping, anemia, abnormal markers for inflammation. So if we have those, it's not IBS. We've talked about what it could be, and we'll continue to talk in future lectures what it could be, but you should have a whole list of differentials in mind at this point of if we're having the alarm symptoms, what do we need to be worried about? Rectal bleed or progressive nocturnal abdominal pain, weight loss, anemia, or a history of cancer. What do they get further work of? Exclude organic etiologies first before we say it's IBS. Diagnosis of exclusion, right? Exclude organic diseases first. And you have to have this tough conversation with your patient after you have excluded things that are badness, that we need to get rid of the badness, or we need to intervene to help them with their issue. If we land on IBS, then we have to make sure our patient understands this is going to be a chronic multifactorial issue. This is not something we can medication away completely. I mean, there's meds we can get, but it's usually going to be chronic waxing and waning. Because if symptoms appear suddenly and acutely, you got to look at something else. It's not IBS. So very important to remember it's chronic and it's not these acute flash to bang symptoms. Think something else. Differential diagnosis is long. Crohn's, ulcerative colitis, we are going to talk about that specifically in IBD next week. Celiac disease, we talked about what it is, and you can see how we have to rule it out. It can be in our differential. Colorectal cancer, lactose intolerant, we just spoke about it. So you can see how some of the signs and symptoms we mentioned can closely overlap with the signs and symptoms of lactose intolerance or decreased lactase. Infectious diarrhea, especially if they're having that IBD prominent IBS. I'm sorry, the IBS diarrhea prominent. So every one of these, if you look at the slide, this is a great memory job slide, right? So here's your down and dirty. What do I see in these disease processes that I don't see in IBS? right? What's the differentiator? What's the thing that should pop out to me in a stem or during the patient history? Oh, you have this, then it's definitely not IBD. Diagnosis, physical exam, pretty unremarkable, usually. Occasionally some mild tenderness. You don't have a hot gut, though. No peritoneal signs, no systemic findings. If you get them, it's something else, usually. Now, the exam can be exaggerated as far as tenderness and palpation somewhat if there is a psychosomatic factor or component present in your patient. Rome criteria. We talked about Rome criteria on the first day. Well, these experts also have us provide us with an IBS diagnostic criteria. The Rome criteria, 1 through 3, you need to know them. 1 day per week, at least 1 day per week, in the past 3 months, you've had at least 2 of those 3 numbered bullets. So 1 day a week in the past 3 months, you have had either related to, i.e. relieved by defecation, abdominal discomfort, or you've had your onset of this recurring abdominal discomfort is associated with how often you're going, and or this recurrent abdominal discomfort you've been having a day per week or every day for the past 3 months. 1 day per week for the past 3 months. You have change in the form of your stool, that Bristol chart, right? I'm usually a 2, now I'm a 6. Usually a 7, now I'm a 3 on the Bristol chart. There's a change in stool form and change in frequency, how often you're going, and or, so 2 of those 3, relieved by defecation, and that's happening at least within 7 days once for the past 3 months. You need to know that entire slide. What does that do? That keeps us from doing a million tests and driving up the anxiety of our patients and getting frustrated as a clinician. Because we have criteria to diagnose IBS. Additional supporting, not one of the primary criteria, but we get asked about the relief of pain, as I mentioned, abnormal stool frequency, increase or decrease, abnormal stool passage, straining versus urgency, so one associated with constipation, one associated with diarrhea. I had that feeling of incomplete passage. You went, but it feels like you need to go again, but you can't go again. Mucus is associated with IBS. So don't jump on mucus as being only inflammatory diarrhea or constipation. You can have some mucus passage on it with IBS. And abdominal bloating or distension. So in addition to the Rome criteria, we have some supporting criteria that leads us even more so towards go ahead and making that diagnosis of IBS, diagnosis of exclusion. Testing, limited. If they have IBS more towards the diarrhea side, go ahead and screen for celiac disease. How do you screen for celiac disease? IgAs, right? That's the specific one. And then you get total IgA, right? And then if that's positive, what do we do? What's the confirmatory? Microscope results, right? We got to look at it under biopsy. Plain abdominal film, everybody got that, right? Serology first, the antibodies. If they're positive, you draw the 2 to begin with, and if you have total decreased deficiency IgA, we can get that special one with a D in it as an alternative. But if we come back with a normal overall IgA and then elevated TT or the one specific for celiac, which I can't remember the entire thing right now, but if it's positive, we're going to confirm that with taking a tissue sample and doing a histological exam and seeing those findings that we saw on the slide. So if they're diarrhea predominant with IBS, you're thinking it's IBS, you can go ahead and check them for CDI. If the patient has predominant diarrhea type IBS, or you're trying to rule in or out predominant diarrhea IBS. For IBS-C, you can go ahead and get some plain abdominal films for that patient, but the labs usually limited to just your basic CBC, CMP, and UA. So what are we going to do? Why are we getting the plain films? We're just going to see if there's signs of that severe constipation on the plain film. Treatment strategies, reassurance, education. They're going to be stressed out because they don't get a definitive organic diagnosis or underlying etiology. So we have to educate our IBS patients on the chronicity and the waxing and waning of the condition and the multifactorial approach. So if there is that psychosomatic axis happening, and then we stress our patient out more, guess what's going to happen more? Their IBS symptoms are going to increase. So a strong patient-provider relationship is required for your IBS patients. Long-term, strong relationship. Because it's chronic and it's going to wax and wane. It came back. I'm back to see you. To continually educate. Yes, this is how this disease process works. Change the diet first. First therapeutic step, usually regular meal times, normal diet, right? Avoid large fatty meals, reduce caffeine, limit foods that produce a lot of gas if you're having a lot of bloating, i.e. beans, cabbage, and FODMAPs. We talked about increased flatus. Our patients with increased flatus, and we can look at FODMAPs and tell them, hey, watch out and try to cut back on those fermentable carbohydrates, the oligos, the dyes, the monosaccharides, and the polyols, the FODMAPs. So we can try a low FODMAP diet. So IBS-D patients, try them on a lactose elimination. Try them on a gluten elimination. See how they do. They don't have sprue. They don't have lactase deficiency, but still we can calm some of their signs and symptoms by limiting what they're putting into their system, which can aggravate their symptoms of the IBS, especially with the diarrhea subtype, lactose and gluten. Try those diets, see if they help. May not. For the IBS-C, they're constipated, treat them like anybody with constipation. Increase their fiber, right? But bring it up slow. Don't have them taking whopping doses of fiber immediately, because if you rapidly increase fiber, you're going to get increased bloating. So slowly increase their fiber. And lots of fluids. Things that promote normal or more normal routine bowel movements. Increase their physical activity is useful in all subtypes. All subtypes get some symptom relief from increasing their physical activity. We can talk about psychological therapies, including CBT, hypnotherapy, relaxation techniques, yoga, different things, multifactorial approaches, mind and body and diet, to address that gut-brain interaction between in IBS that we see in IBS. So IBS-C pharmacological therapy, anti-constipation. So if it's IBS-C, start with an osmotic laxative, PEG, right? Miralax, osmotic laxative. First, you need to know the algorithm for treating IBS-C versus D. First line for IBS-C, osmotic laxative, Miralax, PEG, polyethylene glycol, same thing. That doesn't work, go to the secretox. This is going to increase intestinal fluid secretions. They're constipated, we increase intestinal secretions, and so we can help them with their symptoms and their constipation with these stimulants, intestinal fluid secretion, medications, bupropion, linaclotide, laconitide, and timolol. Got to be usually moderate to severe symptoms of IBS-C before we put on those secret talks. I would know the classes, a couple in the classes, but the main thing is knowing the algorithm. Osmotic laxative, then moving on. More severe secret talks. IBS-D, loperamide. Pretty much what we said, we use in all of our diarrhea patients, except for the ones with what type of diarrhea? Anything inflammatory. We don't want to lock it down and let the inflammation fester. Okay, diarrhea continues after loperamide. We can look at bile acid sequestrants. And there's your normal players there. I think, well, that's actually on the notes there. Cholesterol, cholesterol, colsubilin. If loperamide doesn't work, you can try bile acid sequestrant. Then third line is selective 5-HT3 antagonist. You're not going to be doing those alone. The severe cases, the olosterone, Lotrinix right there, reserved for severe cases. It's only used in female patients because of really bad side effects, and they found it doesn't work in men, and you have to have a special agreement for the providers to use it. So this is going to be a specialist usually, because ischemic colitis can be caused by olacetron, Lotrinix. It's nothing you're going to be prescribing to your patient. That's going to be a specialist because of the side effects. So you're really worried about, do the Imodium, that don't work. Think about the bile salt sequestrants, and if that still doesn't work, your diarrhea is so severe that you think it's worth risking ischemic colitis, and send it to a specialist to talk about the Lotrinix. Offline, off-label, you can try Zofran for your IBS patients after you've tried loperamide and bile salts, and you send them somewhere else to discuss the 5-HT3 antagonist. For IBD, we can also, last line, talk about non-absorbable antibiotics. This is usually just for the significant bloating and excessive gas. So the rifaximin is not systemically absorbed. Usually the rifaximin only for your IBS-D folks with lots of bloating. Minimal systemic absorption. And then we can talk about antispasmodics to help, once again, pain and bloating only. And this is all IBS, not just a subclass, is dicyclomine and icosapine. And then psychotropic agents. Not used as psychotropic agent in our IBS folks, but psychotropic agents that are used in patients with abdominal pain and bloating as their main complaint, and often in IBS-D with anticholinergic effect. And the biggest players that we use in that category is usually your tricyclics, your amitriptyline, nortriptyline. What does that do? It can decrease their visceral hypersensitivity and their abdominal pain. And I just mentioned it's not used. Those tricyclics are not used to treat for their psychotropic effect, specifically for what I mentioned. So if they've got anxiety or depression along with their IBS, treat as a separate anxiety and depression. Don't use the TCA that you're using for abdominal pain and bloating as the fourth line. Probiotics, controversial. If they want to use it, do it. Go for it. Why not? Right? You can't write it for them. But if they want to use probiotics, I see no reason why not to. Easily tolerated, no really issue with toxicity, and it's cheap. If they get a relief from it, then great. Good. Glad they're using it. Long-term prognosis is good, but it is waxing and waning, as I mentioned. And treating these symptoms are trial and error. Some stuff works, some things don't work. Multifactorial approach. The key to this, as I mentioned, is that relationship between you as the provider and the patient. And that brings us to memory jog. Sorry, I went a couple minutes over, but I know your Dr. Brand's coming in like 12:15 to do a review for you. So thank you. Have a great weekend, and we'll see you again on Monday. I'll post the 2 lectures